Okay. Good evening, everyone. I'm Kathy Pabst, Executive Director of the Missouri Academy of Family Physicians, and we're excited to have Dr. Jay Lee here to present adverse childhood experiences and their long-term impact into adulthood. Dr. Lee is the Medical Director at Integrated Health Partners in Southern California and an Associate Clinical Professor of Family Medicine at the University of California, Irvine. He's actively involved in the American Academy of Family Physicians and currently serves on the board of directors. Other AAFP roles include serving on the Commission of Health of the Public and Science and was actively involved in updating the AAFP policy on ACEs. He earned his bachelor's degree in human biology from Stanford University and his medical degree from Keck School of Medicine of the University of Southern California. He completed his residency at the Long Beach Memorial Family Medicine Program in Long Beach, California. He earned his Master of Public Health from Harvard School of Public Health in Boston, Massachusetts. Dr. Lee is board certified by the American Board of Family Medicine, is a diplomate of the American Board of Family Medicine, and has the AAFP degree of fellow and earned degree awarded to family physicians for distinguished service and continuing medical education. Tonight's presentation is delivered live, and the presenter will be available for questions via the chat and following the presentation. Feel free to drop questions into the chat window as they come up during the presentation. We will monitor the questions and moderate them at the end. You are also welcome to speak up and ask questions directly at the end of the presentation. Participation in tonight's presentation qualifies for up to 2 CME credits. The session will be recorded and uploaded to MAFP's YouTube channel for future reference. However, CME is only available for live attendees. Please complete the very short survey at the link I sent in today's reminder email, and that will be dropped into the chat at the end of the presentation. Information entered there will be used to report your CME to AAFP. For non-members, you will be responsible for claiming your CME with your respective credentialing agencies. This session tonight is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services as part of an award totaling $3.7 million with no percentage financed with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. The MAFP is the recipient of a grant from the American Academy of Pediatrics, which is sponsoring tonight's event. So without further ado, please welcome Dr. Lee.
Well, thank you so much, Kathy, for that kind introduction. It's really, truly a pleasure to be here with all of you. Through the wonders of science and the internet, we're all able to beam in together and be together on this Thursday evening. As mentioned, we'll be talking about ACEs, or Adverse Childhood Experiences, and their long-term impact into adulthood. And if I may share, Kathy, I think when you reached out to the AAFP, they spoke with members of the Health of Public and Science. And as a member of that commission, I did have the opportunity to contribute to the AAFP policy. And over probably the last half a dozen years, we've been doing this type of screening routinely in the community health center space. And I think particularly during the pandemic, there was much more interest and research and recommendations around ACEs and really how those upstream factors can impact not only the children that we see in our practices, but also the adults, and in a way, looking back to kind of see what it is that is resulted in them being adults with, various chronic illnesses or behavioral health issues or substance issues. Some of those can be traced back to and triggered and have been triggered by ACEs. So a little bit more about myself. Oh wait, let's see. in case you're wondering, I am a medical director of a clinically integrated network that's a community health center uh, owned and operated. The board that I report to is comprised of community health center leaders. There's 9 health centers in the clinically integrated network, and we service about 400,000 mostly Medicaid recipients in Southern California in 3 counties with 5 different health plans, 2 of which are value-based care plans. I also see patients at KCS Health, primarily immigrants and people leaving the carceral system in Orange County, California. And as such, often find myself uncovering ACEs in my patients, and do spend a lot of time working with not just the medical team, but also the behavioral health team and other community-based organizations to get patients the resources that they need. Kathy did mention that I am a director of the AAFP, and currently at the end of my 2nd year of a 3-year term. And some of you may have heard of Family Medicine Revolution or the hashtag FM Revolution. This is something that we put together, I don't know, about 14 years ago or so, maybe even 15. And it's something that is a place for family physicians to connect in the social media sphere. I'm also a dad, I'm a husband. My last name is Lee. We've got a girl, a boy, and a boy, and our last one's name is Jack, like Jack from The Incredibles. So we have that persona. And then I'm also a Korean American. And as you noted in the lower right-hand corner, I also do live near the beach. I'll say this is the officially sanctioned background for my work. So I'm appreciative of sort of the spirit in which we do this work. Okay, so what are our learning objectives? First is to recognize how ACEs may negatively impact pediatric growth and development. The second is to increase confidence in screening for ACEs. And then the third is to diversify ways to treat adults with history of ACEs. Now, I'm going to reflect on something that a patient once said to me, and their comment was this: my goodness, if I show up even a minute late to my appointment, I realize how much I back you guys up because there's all this screening stuff that happens, and all, in addition to the old school, check my blood pressure and my weight and all that stuff. And it is true. I think we've are in an era right now where there's quite a bit of screening going on, whether it be for depression or for ACEs or anxiety. And a lot of that's become formalized and operationalized. But I think what's really important here is that we're now beginning to understand how a patient's kind of social milieu is impacting their health. I think historically, we did take really good histories on a patient's family and sort of how they grew up, et cetera. But we're realizing that there is correlation when patients have been exposed to multiple traumas throughout their life. And I think it behooves us as family physicians to meet patients where they're at and to work with them, not just with the things that we can prescribe, but also connecting them with the right services that are available in the communities that we serve. So what is our role as family physicians? I think first and foremost, I love this statement, become the physician you wrote about in your personal statement. And if any of us have had the chance to look back at your personal statement, and I don't think we've got the ability to query the group on when they graduated from medical school. But I can assure you that all of us wrote a version of the personal statement that involved something like this. I want to get into this field because the relationships with my patients matter, and I want to have that longitudinal relationship and make a difference not just in the lives of families, but also in the communities that I serve. And I can assure you that nobody wrote in their personal statement, I want to become a physician so I can click on buttons. No one wrote in their personal statement, I want to become a physician so that I can fill out paperwork or do prior authorizations. The work that we do is what calls us. And how do we, I would say, live that spirit in our day-to-day work? And in a strange way, screening and understanding where our patients are from an adverse childhood perspective can help us, I think, achieve some of this sort of spirit in which we came into this work. So if you haven't looked at your personal statement recently, pull it out, take a look at it. I periodically do look at it and am reminded of what it is that I wanted to accomplish in my career. And to date, I feel like I've kind of hit the mark for the most part. I mean, there are days when, you're mired in your inbox work and it feels kind of endless, but, you find those magical moments where you truly help a patient because you've allowed them to feel confident and comfortable in your care in the exam room. So, family physicians and those of us that practice longitudinal comprehensive care, we're heroes. And we're not heroes because we do things like remove organs or cut out cancers and that sort of thing. There's heroism in incremental care. Some of you may remember this article from 2017 now from Atul Gawande that speaks to this in the New Yorker. And he talks about how this steady, intimate care can help people more and kind of more consistently than sort of the one-off transactional care that often is a feature of the healthcare system these days. So, know that what you're doing on a day-to-day basis with your patients, month over month, year over year, is truly making a difference. And I'm a PGY22, and I've got I think my longest standing patient at this point is someone that I've known for about 17 years. And he is somebody that, by virtue of the relationship, has, I've been able to help him in ways that I don't think I would have been able to help if he just came and showed up at my office randomly. It's because of my knowledge of him and his trust in me that I'm able to provide that care. And I think that's a privilege that we all have when we build those deep relationships with patients. This is just a reminder, those of you who may remember Barbara Starfield, she did lots of important research in the area of primary care at an institution that didn't value primary care that much at Johns Hopkins throughout her career. But she characterized primary care through her study and research that it contains 4 C's, right? So it's care that's first contact, care that's continuous over time, care that's comprehensive and concerned for the whole patient, and care that's coordinated across the system. And I think applying these principles to patients who've been exposed or experienced ACEs is exactly the type of approach that we need to take, even if we sometimes feel like we don't have the right tools. By kind of meditating on these 4 C's, we're able to help patients in ways that sometimes are immeasurable. And then you also may remember G. Gale Stevens, one of the godfathers, founding fathers of family medicine. Here he is, he and I both, about 12 years ago, before he passed away. As you can see, we both got the memo that to wear a tan suit to this AAFP meeting. But he gave this stirring plenary address where he talked about fundamentally what we do with patients is to be there. And I love the second one. It's we give a damn, and you can't fake it. And this is really the spirit in which I think the ACEs work that we have the opportunity to do in our office is infused with. And then he said, know the difference between your job versus your work. I mentioned some of the administrative burden that all of us experience. There's aspects of that that are kind of the job, but the work is that transformative work we can do with patients with that incremental care that we provide and deliver over a course of years on behalf of a patient, and sometimes even across generations. So what does this mean for all of us? It means that we're practicing at a pivotal time. We're in an era now where so many more people have a card, especially in states where there was expansion of coverage. But that card doesn't guarantee you access. It's really kind of a hunting license more than anything else. I think we're at this position now in history where we're also very focused on building workforce to be able to meet the demands of the population. And, as physicians, I firmly believe we have a responsibility to be change agents for systems that will deliver better care. And what that means is being at the table, as advocates for not just our patients, but also our colleagues, because none of us would have ever built a system that was where the currency was a 15-minute visit. I think we all recognize how much more complex and challenging our patients have become, and I think we have to think about new ways in which we can continue to impact those patients in an era where we're a bit resource constrained because of the workforce challenges. And then ultimately, our patients will look to us for a guide. So I thought that was important substrate to bring forward before we launched into the conversation of ACEs, because that's really the milieu in which our patients will be coming to us, right? It's that mindset and our approach to the care that we provide. We're not in primary care and in family medicine in particular, we're not, we may work in an urgent care or have same-day visits, but our approach is not sort of transactional. Our approach is really relational. And I think that's why it's very important for us to recognize the importance of ACEs and to do the necessary work to identify them and also to help our patients. Okay, so what are adverse childhood experiences? I think it kind of depends on maybe some generational perspectives on what this may mean, but this is what we are currently calling this. You could call it generational trauma, you could call it all sorts of things, but in the current research literature, this is what it's called: adverse childhood experiences. So this is that policy that was mentioned earlier, and I wanted to highlight this section here in the middle. And this was really the call to action for us as family physicians. So due to the direct impact ACEs have on behavior and health outcomes, the AAFP encourages physicians to learn about ACEs and to recognize the impact ACEs may have on their patients' health. In addition, the AAFP supports programs that aim to, 1, prevent the occurrence of ACEs, 2, reduce the severity of acute consequences of ACEs, 3, treat long-term consequences of ACEs. And examples of these types of programs include, but are not limited to, parental education, parent-child interaction and psychotherapy, dual substance abuse treatment and parenting interventions, and trauma-informed care. Additionally, the AAFP supports research on the effectiveness of ACEs screenings and mitigation strategies to improve health outcomes, and advocates for public policies and legislation to support these initiatives. So let me give you a really good example of this. Prior to my work with Integrated Health Partners, I was the chief medical officer at Venice Family Clinic, at one point one of the largest free clinics in the country in Los Angeles. And not only do we provide primary care there, but we also do have early childhood intervention program. And our philosophy in doing this work, and interestingly, we were one of the few health centers that was involved in early Head Start work. Most of these programs are run through schools, but not necessarily through health centers. And our philosophy there is that, yes, we're going to spend a lot of time and energy in doing the important work of working to fix broken adults, but the best way to avoid and to prevent broken adults is to heal children. And I continue to believe that that's true. I think we spend a lot of time in health centers working to help, particularly broken adults, but one undervalued aspect of what we do in the community health center space is really to help support children and their health. And so ACEs can be a big part of that, to identify what resources parents may need, what resources there may need to be in the community, how to partner with schools and other community-based organizations. And then I think for adults, a lot of it is around connection to embedded behavioral health, if you have that available in your clinic. And then other things like housing navigation and food support for those that may be experiencing food insecurity. All right, so let's talk about exactly what are adverse childhood experiences. It's not to say that every traumatic effect is going to impact the child for the rest of their life. And a lot of it depends on that child's inherent resiliency. It also depends on community factors and family factors, et cetera. So I think the word potentially is very important here. So potentially traumatic events that occur in childhood. So that just very simply, that's what an ACE is. So examples include, but are not limited to, and if we did a round robin here, I bet each of us could come up with this entire list, just in terms of the patients that we care for. But things like experiencing violence, abuse, or neglect, experiencing discrimination, witnessing violence in the home or community, having a family member attempt or die by suicide, housing instability, not having enough food to eat, or growing up in a household with substance use problems, mental health problems, instability to parental separation, and instability due to household members being in jail or prison. I mentioned earlier that this current clinical setting where I work is many immigrant families, and then also those families impacted by the carceral system. And the way that came about, and the way the clinic built its reputation, is through working closely with the court system. As it turns out, there was not a lot of resources for non-English speaking immigrants if they got caught drinking while driving. And so a lot of patients were sent to court-mandated therapy and after a DUI arrest, and unfortunately didn't have the opportunity to find places where they could get court-mandated therapy. And so that's kind of how my clinic started, was really as a BH shop. And then over time, what they realized is there was a real need for patients to have medical care and dental care and other things along those lines. And so as a result, many of the patients that I meet and have the opportunity and have the privilege to take care of are folks that have experienced ACEs. And culturally, for some, it's really hard to kind of bring this up. And so I think the screening can help bring that out in ways that are not intended to cause additional trauma. And you can quite simply count the number of ACEs that someone may have experienced, and then decide how intensely you want to intervene and help those patients. But we'll talk a little bit more about that in just a bit. But that's what ACEs are, quite simply traumatic events that could impact someone down the road. If you're more of a visual person, there are 10 categories of ACEs, and they can be bucketed into abuse, neglect, or household dysfunction. So abuse can come in the form of physical abuse, emotional abuse, and sexual abuse. Neglect can be physical or emotional neglect. And household dysfunction can be related to those that are in the house that may be experiencing mental illness. Earlier, we mentioned incarcerated relatives, substance abuse in the house. The mother is treated violently, and divorce. So these are things that we often will hear about in a patient's background and story. And sometimes patients are a little bit more forthcoming and open about it, and other times, it's sort of hidden under the surface. And when I used to teach residents at the residency program, sometimes the resident would come to me panicked because they would say, "Dr. Lee, the patient's crying." And my response oftentimes was, well, did you make them cry or did you allow them to cry? And I think that's a really important distinction, right? None of us wants to be that terrible doctor that makes patients cry, but we would all love to be that sort of caring figure that allows patients to feel vulnerable and to speak up. And sometimes it comes at the worst time because you might be two patients behind. But those are also the moments where I've just learned as a PGY22 at this point to just slow down, take a deep breath, sit down and listen, because that's when your patient needs you most. And that's, as G. Gale Stevens said earlier, as I mentioned, that's the moment when you really want to show that you're giving a damn about your patient. Okay, so you're probably asking the question, yeah, okay, these ACEs are around, and but how many people are we talking about? Is it a small amount? Is it a large amount? And as you can see here from this statistic, 64% of adults in the United States have reported they've experienced at least one ACE before the age of 18. And 17% have reported experiencing 4 or more ACEs. So what that tells me is that, and I should say, I think this may be underreported because this is all self-report, but you can say that it's definitely happening in a majority of people, that most of us had some form of traumatic experience in our life that would count as an ACE. I'm very interested especially in the 17% that have 4 or more ACEs. And I'll show you data a little bit later on that just shows how impactful that can be, not just from a health burden perspective, but also from a utilization and cost and perspective. So this is part of the reason why it's very important for us to be able to quantify what may be going on with our patients so that we can unlock the resources that the patients need. As I noted earlier, if we're able to prevent ACEs, that could significantly reduce disease burden. Up to 1.9 million cases of heart disease and 21 million are estimated to be attributable to ACEs. It's something that clearly has a halo effect and can impact what's going on with our patients' lives. And it behooves us to kind of think beyond the statin, I would say, in order to help these folks in their healing process. So are all children at risk for ACEs? And the short answer is yes. As noted earlier, 2/3 of the population have been impacted by at least one ACE. 17% have been exposed to 4 or more. But not everyone experiences ACEs in the same way. So who's at greater risk of experiencing ACEs that have a negative impact? Those are individuals who come from historical, social, and economic environments where they experience inequality. The highest rates are amongst females, non-Hispanic American Indians or Alaska Native adults, and adults who are unemployed or unable to work. So, your spidey senses should be tingling if you uncover ACEs in someone who comes from a historically uh, uh, a historically burdened population. And the reason why the spidey senses should be tingling is that may be impacting their overall health. And if you're able to address some of those factors and reduce harm, it can have a positive impact on the patient's health. Okay, so why do ACEs matter? We've been kind of implying that they do have health impacts. So let's go over that a little bit. They also do impact not just the health, but also some of the social determinants of health as well. So there's definitely concerns about health and well-being. For a lot of kids, there can be risk of injury when exposed to ACEs. And then, of course, down the line, we worry about chronic disease. In addition, there's evidence to show that ACEs can impact education, educational attainment, as well as job potential. So, if we're able to, again, impact the children and prevent them from becoming broken adults, there's an opportunity for us to, prevent some downstream impacts of those ACEs for our patients. So a big piece of this is stress, and in particular, it's toxic stress, because we know that not all stress is bad, right? Stress is probably what helped us get through medical school and to survive residency. Stress can oftentimes help us when we're competing in sports or other competitive endeavors. So positive stress is good. We need some of that, a little bit of epinephrine in our life to kind of move things along. So, that's that brief elevation in stress hormones in your heart rate and your blood pressure, and that's to a routine stressor. There may be an elevation in that to what we would call tolerable stress, and that kind of depends on your level of personal resiliency and your ability to cope with those things. But this is a time-limited activation of stress response. And if it's buffered with relationships, and in the case of children, adults who can help them adapt, then the kid will be just fine and there shouldn't be an issue. This is kind of a comical example, but the first time that my middle child and I were on a merry-go-round, he looked terrified, and but then he saw in my face that I was having a great time, and his look of terror ended up becoming uncontrollable laughter. And I think that's just a really superficial example, but one where I think that having that trusting adult around to kind of help interpret the world, if you will, can help children adapt to whatever stress there may be. What we really get concerned about, though, is toxic stress. And this is the best way to think about this is allostatic load, right? High doses of adversity experienced during critical and sensitive periods, let's call those core memories, during early development. There's no buffering or there's inadequate buffering. And then they become sort of biologically embedded. And there's this sort of chronic toxic stress response that ends up coming out from that. And as I mentioned, it becomes kind of an allostatic load issue, right? The child can only take so much, and then at some point they're going to have maladaptive responses to those toxic stress elements. So as you might imagine, that can impact brain development. It can impact the immune system. It can impact stress response systems. And then that then impacts and affects attention, decision-making, and learning, which then may cause difficulty forming healthy and stable relationships. That can result in unstable work histories as adults, struggling with finances, job, depression, and then of course all the chronic health issues like diabetes, hypertension, hyperlipidemia, etc. Um, and we know that, and we're aware that this can be passed on to future generations through this sort of negative feedback cycle. And so, if we're able to intervene at a point in a child's growth and development and try to break that cycle, then we should do our best to try to make that happen. It's not going to always be successful, but I think ultimately what we're trying to do is to reduce harm to that child and allow them to live their best life possible. Okay, so let's talk a little bit about sort of what this cycle might look like. Again, if you're sort of a visual person, it's that early life adversity, and there you might have some predisposed vulnerabilities, you might have some protective factors. That plays out with this neuroimmune endocrine regulation process. And the end result is that there may be some clinical implications in the various systems: endocrine, metabolic, reproductive, neurologic, psychiatric, etc. And so to the degree that we can work upstream and stop these factors or prevent them from creating permanent change, the more power to us from a physician perspective. Okay, so you might be asking yourself, okay, that's fine and good. This is feels very theoretical. There's a lot of words that Dr. Lee kind of threw at me, but I can assure you, patients are showing up to your office with presenting with the result of ACEs, or or not just the result, but also being just very impacted by ACEs. So in children and babies, you could see them come in as a failure to thrive case, where you're trying to figure out what's going on, and there may be traumatic impacts that are causing that child to fail to thrive. There could be growth delays that you're witnessing in your patients. Patients that come in with sleep disruptions or other developmental delays may be the result of being exposed to ACEs. So, I think we all do a really good job of working to understand the milieu that our patients are growing up in. But, when these types of things present in your office, one of the things to think about is, what types of ACEs may be impacting this patient. For school-age children, this may show up as frequent viral infections, even cases of pneumonia, asthma, and atopic diseases. And then I think classically difficulties with learning and behavior, right? We often think about what the home environment's like. Certainly when we're assessing, for example, attention deficit, we want to know, is that patient's behavior consistent across the home and at school, or is it just appearing in one place or the other? And so I think that should definitely be on your radar if kids are coming to the office with these things. And then it gets more complicated, right? As our patients age and develop. So for adolescents, they may come in with vague somatic complaints, including headache and abdominal pain. Sometimes this manifests as high-risk behaviors. Teenage pregnancy or paternity could be related. Sexually transmitted infections, mental health disorders, and certainly substance abuse. And then as patients develop into adults, then we start thinking about things like diabetes, maybe, for example, the patient was food insecure as a child, and therefore they got high density, high caloric foods that were relatively inexpensive, not fresh food, little exercise, et cetera, and kind of put them into insulin resistance and ultimately diabetes. COPD and asthma, as we mentioned earlier, certainly cardiovascular disease, certain types of cancer could be more prevalent, depression and anxiety, substance use, chronic pain, and then PTSD. So, I'm not saying that everything is an ACE, but I'm saying when you see things that are concerning and it's coupled with positive ACEs screening, that the patient may need more than sort of medical care. They may need to be connected with other resources in order to help them to the best that we can. So, how do we break the cycle? I think, and I think this is the thing that both enthralls us and exhausts us, is figuring out how best to help some of our more complex and troubled patients. It's the thing that keeps me up at night, oftentimes, is thinking about patients where I'm having challenges figuring out how to get what the patient needs from the system and for me to be able to help them as best as I can. And I think ultimately, as perfectionists, relative perfectionists, this is part of what we struggle with, is that it's not always textbook. It's not always something that we're able to make as big of the impact that we want to, but it doesn't mean that we shouldn't try. And part of the reason is that no child or individual is at fault for the ACEs they experience. And many of you may remember this iconic scene in Good Will Hunting, where the psychiatrist character played by Robin Williams says repeatedly to the oh my God, Matt Damon. I almost forgot his name. Matt Damon's character. It's not your fault. It's not your fault. And then that results in Matt Damon's character completely breaking down emotionally, and this sort of beautiful cinematic hug that happened. And from what I understand, psychiatrists or psychologists don't normally hug their patients, so then you knew that it was really Hollywood in this case. But it's true. None of it is a child or individual's fault that they experienced it. It's just what the world brought to them, and our job is to uncover it and to acknowledge it, and then to work with the patients to help them as best as possible. And I'm sure many of you have been in this situation where patients start to share more with you, and then you uncover real historical challenges that the patient has experienced. And that's part of what makes family medicine beautiful, and what that continuity of care kind of that fills our cup. So there are risk factors that are attributable to individuals and families, and then there are risk factors that are related to the community. So let's start with the community first. If you live in a zip code where there's high rates of violence and crime, there's high rates of poverty and limited educational economic opportunities, high rates of unemployment, easy access to drugs and alcohol, low cohesion or community involvement, few community activities for young people, unstable housing where residents move frequently, high rates of food insecurity, high levels of social and environmental disorder, you may be exposed to ACEs, right? You may be more likely to have been exposed to ACEs. So we know that these are, and none of these are things that you and I can fix with a prescription. These are all policy things that happen upstream and are determined by people that are not MDs or DOs. These are by and large impacted by people who are policymakers and decision makers in communities. And so it behooves us as physicians to speak out on these items and to be at that table on behalf of our patients. On the individual and family side, it's things like lack of closeness or communication, youth who start dating early or engage in early coitarchy, social isolation and or aggression, low education, low income, history of abuse and neglect, young or single parents, high parenting and or economic stress, inconsistent discipline and low levels of parental monitoring and supervision, high conflict households, and then caregiving challenges related to children with special needs. So these are individual and family factors, and when they play with or interact with those community factors, those can either be amplifying or, in some cases additive. And so, depending on where you work and the types of patients and families that are your patients, I think it's just important to be aware of that these factors may be impacting, your patient's ability to respond to your treatment plan. And so, have some patience. It's not their fault, but these are things that, as we become aware of them, we can begin to think about ways to connect them with community resources that can be helpful. There are also protective factors. So let's start in this case with the individual and family. So safe, stable, and nurturing relationships, positive friendships and peer networks, doing well in school, caring adults outside the family. Your basic needs are met. As it turns out, that Maslow guy knew what he was talking about, right? Basic hierarchy of needs. Community individuals and families where college degrees are present have a protective factor. Steady employment, strong social support networks and positive relationships, consistent parental monitoring, caregivers and adults who work through conflicts peacefully, caregivers and adults that help children work through problems, families that engage in fun and positive activities, and families that encourage the importance of school for children. So in a lot of ways, this is sort of the mirror opposite of the risk factors that we saw on the earlier slide. And quite frankly, I think this is the aim that we're targeting for, right? Is to ensure that our patients have those protective factors available to them. Now, on the community side, a lot of it has to do with access to economic and financial help, medical care and mental health services, safe and stable housing, nurturing and safe childcare, safe and engaging after-school programs, high-quality preschool, work opportunities with family-friendly policies, strong partnerships between the community and business, healthcare, government, and other sectors. Residents feel connected to each other, and then violence is not tolerated or accepted. So again, I think this is an ideal and maybe an infinite asymptote that we, because perfection is impossible. But our goal should be to strive to create communities where these things are available to our patients. And then, of course, from the individual and family perspective, as you might imagine, there's some synergies there between the individual and family factors and the community factors. And depending on where you live, there's probably a milieu of different both risk and protective factors that are at play. And again, part of our job is to meet the patients where they're at, because none of this is necessarily their fault. It's just a matter of understanding where they're at and meeting them there. Okay, so to that extent, as I mentioned, there are things that we can do, and because I'm a PGY22, I remember the days when we would write actually on prescription pads. And I used to say, oh, these are things I can't fix on a prescription. I guess it's clicking a button these days in the EMRs. But, there are things that we can do, referrals, et cetera, that are going to help patients. But I think the other piece of this is that there are things that are a little bit further upstream that we as family physicians may not have a direct impact on, but we can certainly speak out on as individuals that live in a community and that are viewed as leaders by virtue of our stethoscope or a white coat. And so it's things like strengthening economic supports to families, financial security is obviously very important, family-friendly work policies. I'll give you an example. In the community health center where I worked, I referenced Venice Family Clinic earlier. Part of the early Head Start program was job training for parents who might be unemployed or underemployed, and that opportunity to strengthen their microeconomics was a pathway to helping them with some of their other health and behavioral issues as well. Promoting social norms that protect against violence and adversity. So, there are a ton of, I would say, public ads out there about the importance of not bullying, etc. And so that's certainly out there. Trying to reduce corporal punishment. I'm of a generation when early in my life that was still allowed, when parents could spank children. Obviously, we don't allow. It's frowned upon these days, but that sort of violence is not acceptable now. There are definitely things like bystander approaches in how you, as somebody in the community, can step in and de-escalate a situation that may turn into violence. And then men and boys as allies in prevention, particularly when it comes to violence against women in a community. Ensuring a strong start for children. I'll reference the Early Head Start program that worked as part of the clinic back when I was at Venice. And a lot of that included field time for our liaisons to go out and visit the home, do a safety check, report back to the clinical teams on what was going on, and then provide teaching and guidance for those parents, as well as working to get children into early preschool so that they can be enriched and really kind of use that as a springboard to live a productive and happy life. There's certainly skills that can be taught. Again, in this early Head Start program that was connected with the clinic, a lot of coaching around social and emotional learning with the parents, who then can work with their child or model that behavior for their children as they grow. Safe dating and healthy relationship skills programs, parenting skills and family relationship approaches. These are all things that are evidence-based and can be helpful for creating, standards by which individuals and communities can live. You've probably seen in many communities, opportunities for children to convene in safe environments. So that could be an after-school program, a boys and girls club, mentoring programs. All these things matter, and some of you may be involved in those types of activities. I work at one of the things I do in my free time. I'm on the board for a not-for-profit that is focused on children and especially children who've been victims. And a lot of what our board supports is things like after-school programs and mentoring, et cetera. And it's really powerful and super important that we continue to offer that to our patients. And then intervening to lessen immediate and long-term harms. So primary care, we're a big piece of that. Usual source of care is going to be important. I love having, there was a time when I was still delivering babies, and I loved being able to see children grow over the years and having that relationship. And especially, I think with the advent of some of the asynchronous work that we do, kind of being able to be there for patients when they need us, even if it means that they don't come to the office. And I'll share with you a little bit later that, I think we're starting to look at metrics that are more patient-centered. And it's things like, the doctor and I have been through a lot together. The doctor has my back. To me, those are things that are indicative of excellent primary care. And yet health plans are often measuring things that really have questionable impact on a patient's health. Who cares how many times I check a hemoglobin A1C it may make a difference, but really, does the doctor, are they there when you need them, kind of thing, is I would argue is more important in the long run. I mentioned victim-centered services, and then a treatment to lessen the harms of ACEs. So when you have a patient who, for example, is in substance use, has a substance use disorder, ensuring that they have access to medication-assisted treatment, and the really important component of that is the behavioral health aspect. So there are lots of things that we can do. A lot of it is going to be outside the four walls of the clinic. Some of it are going to be things that we can do in the clinic. And then a lot of it is going to be us connecting the dots and ensuring that patients get to the right resources to be able to avail themselves of those community resources. So not to be totally cheesy, and we're not going to break out into song here, but this song lyric from Whitney Houston always plays in my head when I think about ACEs. I believe the children are our future. Teach them well and let them lead the way. Show them all the beauty they possess inside. And there's some truth to that, right? There's a lot of truth to that. There's nothing, as a parent, there's nothing more that I want for my children than to live their best life. And it breaks my heart anytime I've got patients who are struggling because of their exposure to ACEs in their life. And sometimes there are things that I can do, sometimes there are things that I can't, but every time I'm working to try to reduce harm to them and to allow them to live the best life that they can. And I think that's the best that we can do as family physicians sometimes. But that's what grounds me every day, and what keeps me coming to work is the opportunity to be able to make a difference in people's lives. Okay, so we just spent a good amount of time talking about ACEs, what they are, what are some risks for ACEs, what are some protective factors for ACEs, what toxic stress is, and some aspects of a child's life and social milieu that can make them more at risk and make them less at risk for this. So a patient comes to your office, how do you screen for ACEs? And I will share that in the state of California, for those that have Medicaid, there are mechanisms in place for physicians to get essentially a fee or payment for doing the screenings that happened during the pandemic. And I think it's been scaled up variably. And so there are codes that exist that you can put in that count towards this. And there are databases being built as we speak. But it's, I would say, by and large, fairly clunky. But that being said, I think there's ways to make it less so. And some of that comes down to methodology and how you intend on using the screening tools. So let's get into that a little bit. And by no means is this meant to be an exhaustive list of screening tools, but these are the ones that I certainly I've been using, and that have been things that we've been using here in California, where I am currently. So I think it's important to call this out, that when you do screening, there's two ways of doing it. There's de-identified screening, and what that means is someone looks at a list of ACEs and they count roughly how many they've got, and then they write a score on the sheet. The identified screening is one where they circle what it is that impacted them, and then you count them up. And as you might imagine, de-identified results in a higher compliance rate, a higher rate of disclosure for patients, because they don't have to call out the fact that maybe they saw someone commit suicide or that they were sexually abused. But getting that total score is important because, as you'll see, there's a dose response. If you've got 5 ACEs in your life, then you're much more likely to be impacted than someone who's had 1 or 2 ACEs. I'll also note that this is available in 17 different languages, the tools that I'm about to share with you. And oftentimes this is, I would argue, operationally speaking, isn't something that is easily done with just with a singular MA. And so you may need to identify somebody who's an ACE champion. We had someone from our front desk who would rotate, and as patients were coming in, they would work to help facilitate collection of the screening tool. And then we did this de-identified screening methodology and found pretty good success in getting patients to respond to that. So something to keep in mind. There are different tools depending on whether it's a child or adolescent or an adult that comes through your practice, but it's the same idea. You're counting up the number of exposures that they may have had. So this one is called PEARLS, and it's Pediatric ACEs and Related Life Events Screener, PEARLS for short. And there's different tools. So for kids ages 0 to 11, it's to be completed by a caregiver. The teens have the opportunity to complete this either on their own or to have their parents complete it themselves. But suffice it to say, and there's also de-identified and identified versions of this that are available. If you Google PEARLS screening, you'll be able to find these on the internet. And there's a little disclaimer on there that just says that you're going to use this for good, not evil. And then you click on that button that says that you're going to use it for good, and then you can gain access to it. Okay, so this is what the screening tool looks like. As you can see, it's I quote unquote printed this on one sheet of paper, but it's intended to be two-sided paper. And let's just run through this real quickly because I think there's both time and value in going through it, and so you can see the direction that the questions are asking. So, has your child ever lived with a parent or caregiver who went to jail or prison? Do you think your child ever felt unsupported, unloved, or unprotected? Has your child ever lived with a parent or caregiver who had a mental health issue? Has a parent or caregiver ever insulted, humiliated, or put down your child? Has the child's biological parent or any caregiver ever had or currently has a problem with too much alcohol, drugs, or prescription medication use? Has your child ever lacked appropriate care by any caregiver? So this is the neglect question. Has your child ever seen or heard a parent, caregiver being screamed at, sworn at, insulted, or humiliated by another adult? Has any adult in the household often or very often pushed, grabbed, slapped, or thrown something at your child? Has your child ever experienced sexual abuse? Have there ever been significant changes in the relationship status of the child's caregiver? Has your child ever seen, heard, or been a victim of violence in your neighborhood, community, or school? Has your child experienced discrimination? Has your child ever had problems with housing? Have you ever worried that your child did not have enough food to eat? Has your child ever been separated from the parent due to foster care or immigration? Has your child ever lived with a parent or caregiver who had a serious physical illness or disability? And has your child ever lived with a parent or caregiver who died? And so for the purposes of the de-identified, this would just be a tallying up of, mentally, internally a checklist. And then you add up those scores, and then, you'll get the number of ACEs that the patient's been exposed to. In the beginning, back about 8 or 9 years ago, we were still doing this as an identified test, and we quickly learned that patients aren't as open when there's identification. So we did work to make these de-identified, and I think have had better success in getting patients to respond. So you can see a lot of the things that I pointed out in the first part of this talk are captured in these types of questions. And this is part of the reason why this is very hard for an MA to do. It's going to require a little bit more nuance and sensitivity than that, period of time in the 15-minute or 20-minute visit that you have to get the patient inserted into the room. So for adults, it looks very similar. And again, you can do this as de-identified or identified, and I'm strongly recommending that you consider doing this as in a de-identified format. But did you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or take care of you? Did you lose a parent through divorce, abandonment, death, or other reason? Did you live with anyone who's depressed, mentally ill, or attempted suicide? Did you live with anyone who had a problem with drinking or using drugs? Did you or adults in your home ever hit, punch, beat, or threaten to harm each other? Did you live with anyone who went to jail or prison? Did a parent or adult in your home ever swear at you, insult you, or put you down? Did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Did you feel that no one in your family loved you or thought you were special? And did you experience unwanted sexual contact, such as fondling, etc.? And so you can see this is the lens of the adult reflecting back on their life and the impact of ACEs in their mind. And again, this is something where you'll probably have more success asking this in a de-identified way and then have them give you a total score so that you can determine sort of how, I guess, robustly you'd like to respond to that. So a little bit about scoring rubric, and in this case, this is primarily for determining, it's a way of risk stratifying, right? So if someone has a few or 0 to 3 ACEs and they don't have any health conditions, you want to let them know, hey, I want you to be aware of what ACEs are. You didn't identify which ones they were. You're aware of what those are. Just know that, those things can cause stress. You want to build your ability to be resilient and, assess for protective factors. For those that are in that intermediate risk category, there's that 1 to 3 intermediate risk. And then, you want to assess whether or not they've got health conditions, but especially if they have health conditions, then you want to provide that same education and then link them to support or services, whether that be behavioral health therapy or other factors. You'll be able to make that call best with informed consent with the patient. But it's that 4 or more ACEs bit that is the situation where your patients are going to be at greatest risk for having health manifestations of the ACEs exposure that they had. And then there are going to be times when patients just don't score it because they're uncomfortable. And that's okay too. Just let them know that the reasons why you're interested in it and how it may or may not impact their health. And so you can offer it then at the next visit. So just keep in mind, you don't have to force people to do it, but there are going to be times when patients don't answer completely, and that's totally okay. You just let them know that you're going to ask about it again. It's almost like asking about smoking. Sometimes patients just don't want you to ask, but you're going to ask anyway, and you let them know that I'm going to ask you next time I see you, and not in a threatening way, but in a way that shows that you care. As I mentioned earlier, there are billing codes for these screenings, and depending on the market where you work, they may or may not be recognized. As I mentioned, in the state of California, we do have an ability to get reimbursed for these screenings, and the reimbursement depends on how many factors you identify in that screening itself. So the G9919 code is that for high risk for toxic stress. And then the G9920 code is for those that have low risk for toxic stress. So again, your mileage may vary here, but I just thought I'd call that out as being something that is potentially an opportunity for you. I'm not sure what it's like in the state of Missouri, and I would love to hear from you all when we're all done here, or if you want to drop in chat whether that's something that's available to you, that would be good for me to know. As you may be aware, I'll wear my director hat for a little bit. We do have a Center for State Health Policy, and there's an individual named Julie Harrison who's the subject matter expert who works very closely with different state chapters to help them develop policies that can be helpful. And this is certainly one of those areas where we think it would be a great benefit to family physicians and other primary care clinicians to be able to be recognized financially for doing the screenings. I'm going to have a quick sip of my drink here. All righty. So we talked about what ACEs are. We've talked about how to screen for ACEs. And I think this is the punchline, right? We wanted to have the conversation about what is the long-term impact of ACEs on adult patients. And totally dumb luck. I mean, there's a lot of literature out there, but totally dumb luck on my part. And coincidentally, this wonderful article with robust data was published in July in Health Affairs. So in this particular study, they looked at 2021 Medical Expenditure Panel Survey, Household Component, or MEPS-HC, to provide the first nationally representative estimates of ACEs-related healthcare utilization and expenditure differences. So many of the previous study or the studies prior to this were kind of piecemeal studies looking at, I would say, pockets of populations. This is taking national data and giving us, I would say, a much more robust picture of what the impact is on adults. And so lucky us, this got published about a month ago, and I borrowed and stole from it heavily for the purposes of this lecture, because I do think it's very informative and tells me that there's opportunity for us to really impact this, not just from the policy perspective, but also in how we approach care of our patients in the office. Okay, so here's a summary of the findings from this paper. So similar to what we saw earlier from the data that I presented in the beginning part of the lecture, 62% reported any ACEs. So on average, I think the number that I presented earlier was 64%. In this case, it's 62.6%, a little bit more exact. That represents 157 million, 0.6 million people in this country that have reported any ACEs. Of those, 41.7 or 105 million roughly reported 1 to 3 ACEs. So in that sort of intermediate or sort of low intermediate risk, especially if they've got health issues. And then 21% of those, or 52.7 million, reported 4 or more ACEs. And as I mentioned earlier, there's a little bit of a dose response here. So the more ACEs that you've been exposed to, the more likely you are to be impacted by them from a health perspective. Sort of interesting here, there are generational differences to the way ACEs pop up, and that may be generational, but also related to sort of maybe sort of recall, actual exposure to ACEs, et cetera. But 28% of the respondents were more likely to be 25 to 34 years old, and then half as likely were to be 75 to 84. So it does trend a bit younger. Other trends, similar to previous studies, more likely to be female, less likely to be Hispanic or non-Hispanic Asian, and more likely to live in the West. So interesting, because they did have a national sample here. They were able to regionalize some of this, and also, I think, sort of confirm some of the earlier findings from earlier studies that were done. So again, as I mentioned, you know, the 4 or more ACEs is what we're super concerned about, and where we think that there's a great amount of opportunity to make a difference. So those with 4 or more ACEs were more likely to report adverse adult circumstances, and those relationships between the ACEs and those circumstances were strong and graded. So there was a stronger correlation for those patients who had 4 or more ACEs. So to summarize, what that looked like was they were more than twice as likely to report little or no life satisfaction. They were 5 times as likely to report being physically harmed or threatened in their lifetime. And then there were other similarly strong relationships and correlation to verbal abuse, financial problems, housing problems, food insecurity, feeling stressed, social network problems, exposure to crime, and discrimination. So again, I think one of the big takeaways for me in this paper and in now prepping for this work, but also I think bears out in my own clinical practice, is that when patients have more stuff that's happened to them, they're more likely to have show manifestations, and some of that can be perception of um, uh, the patient's own self-perception and their own sense of self, but it can also have impacts on their actual health and well-being as well. And part of this is that perception is powerful, right? And so to the extent that we're able to help our patients come to terms with this, acknowledge that these things happen in their life, and in spite of that, are able to kind of make a difference, I think that that's a very powerful thing that we can do. So interestingly, again, this was nationalized data through the MEPS survey. Except for cancer, adults with 4 or more ACEs were more likely to have been told by a doctor that they have a chronic disease overall. There's a relative risk of 1.54. So 18.5% of those patients with 4 or more ACEs had heart disease. And then 17% of those patients had 4 or more chronic conditions with a relative risk of 1.47. We all know those patients, the ones who have a problem list that's multiple pages. Back in the old days, when we would have a cover sheet in the paper chart, those are the sort of multiple volume patients, I would call them, where they just got a lot of things going on, and it's sort of a pick which chronic disease you're gonna take care of on that particular day. But there's a correlation here for those patients that have more ACEs are more likely to be more impacted by chronic illness. I mentioned perception earlier, and old school like SF 36 surveys. I don't know if you guys remember those. Maybe I'm aging myself here. But those are the old school Scantron surveys that folks used to do on reported and perceived health status. Those folks were twice as more likely to report fair health status and more than 3 times more likely to report health status than those with 0 or 1 ACEs. So again, that perception and of their own health is impacted by the presence of ACEs. As far as depression and psychological distress, 3.73 times as likely to have depression, 2.57 times as likely to have had some type of psychological distress, and 6.37 times as likely to have serious psychological distress. And so, sometimes when you walk into a room with a patient that has multiple ACEs, it can feel disorganized and challenging to get sort of rankle control in those visits. And some of that can be due to sort of this superimposed behavioral health, psychological distress that's going on. And again, it's not the patient's fault, but part of our job is to acknowledge it and to learn how to manage that. And I've certainly gotten better over the years, managing the sort of chaos that can come with some of these patients. But it's never perfect, and so I come back day to day to try to do my best to help my patients out as best as possible. And clearly, the relationships that we build with our patients can help a ton with that. And then for those patients with 4 or more ACEs, some other data that may or may not be surprising to you is they're more likely to engage in risky behaviors. So things like smoking, vaping, excessive alcohol use, not exercising regularly, having problems sleeping, and having a high BMI. These are all things that are correlated with having 4 or more ACEs. So how does that impact healthcare utilization? And to me, this was arguably the most interesting aspect of this paper. And you can see here that they measured this across the board, that almost a 30% more increase in prescription refills. So that's a proxy for chronic illness, right? That there are going to be more prescriptions. There's 35% more subspecialist visits. That may be due to actual disease. It also may be due to increased workups for patients with vague symptomatology. I mentioned headaches and abdominal pain earlier for some adolescents. That can certainly be something that shows up amongst your adult patients as well. And sometimes they'll say things that, your spidey senses go, I just got to rule this out and make sure that there's not a problem here. And so that's when you dial a friend and you coordinate care and work to get those referrals to happen. Unsurprisingly, there's more ER visits. In the network where I work currently at Integrated Health Partners, we've identified this as an opportunity for us to intervene with patients, where we do have actually almost this amount increase in emergency department visits amongst those patients with 4 or more ACEs. So our local data supports this national data, and for those patients, we've actually been engaging them in enhanced care management, where they have a buddy who's a non-licensed person who then is that connector that gets them back into their primary care medical home. And we have yet to see a change, but because it's a relatively new program, but I suspect that we should be able to bend that curve and get them rehomed in their medical home with their primary care physician. 22% more hospital admits, and then interestingly, 20%, 21% more primary care visits as well. Part of this could be related to chronic disease burden, but it also could be related to things like anxiety and depression and vague symptoms, as I mentioned earlier, and more need for workup and handholding for patients. So super interesting to me. I would say it confirms some of the things that I've observed in my own clinical practice. You may have agreed that this is something that you're seeing as well. And then what's the end result? And this is why it's such an important policy question, especially when we're in this era of value-based care, where we want to, increase value and want to ensure that there's reasonable spend and not breaking the bank as far as patients go. But the reason why this is important is that the end result is that this survey or this analysis has shown that patients with 4 or more ACEs result on average in a 26.3% higher expenditure overall. And I think that's really important as we're talking about spend in the country as a percentage of GDP being nearly 20%. If we could cut that down by 26% because we have, let's call it perfect interventions on ACEs and the impacts of ACEs, we could be doing so much more with that healthcare dollar, right? And then I'll also call out the fact that primary care spend is only 5 to 8 cents of every dollar. And if we increased primary care spend and empowered us to do more for patients through building of programs and other staff members that can support the care that we provide, imagine how powerful that could be. Because, I don't know about you, but if I had a patient with a hemoglobin of 5 or 8, I would freak out, and I would get to the root cause of that. I would work to double that patient's hemoglobin. And I think that's the situation that we're in this country, where we're woefully underspending in primary care. And imagine if you doubled your budget, not doubled your salary. I mean, that would be great too, but if you doubled your budget and your ability to impact patients, how powerful that could be. So let's break that down a little bit. The 26.3% higher is on average, as I mentioned. For those with 1 to 3 ACEs, that's actually 20.8% more. But again, that 4+ ACEs, that's sort of that dividing line, those patients end up being closer to 37% more spending and expenditure and utilization on average. So the difference, when you do the math, is $292 billion of spending that, arguably it's important, but I would say, if we could prevent that with this current generation of children, how much of an impact would that have for future generations in terms of overall spending, especially when we're concerned about breaking the Medicare bank, right, for older patients. So that $292 billion was 14% of adult expenditures in the MEPS survey. There's a disproportionate amount of impact on Medicaid spending, so 29%. 13.7% of that was out-of-pocket spend, 12.8% was private insurance spend, and then it was about 10% of Medicare spend. So, damn it, Jim, I'm a doctor, not a ... I'm not an economist, but it concerns me when patients are, A, impacted by ACEs, but B, to me, it feels like there's an opportunity for us to kind of bend that curve. And there's opportunity cost, right? Like, I think there's an opportunity for us to, if we're able to make those investments in children and adolescents, we could see a situation in a generation where we've bent that curve, and then we can reinvest those dollars that otherwise would have been spent on ACEs mitigation, let's call it, on things like vaccines, on things like other technologies that can help patients, et cetera. So I think there's a missed opportunity. And then, as I mentioned, I think there's an opportunity for us to be thinking better about how we spend healthcare dollars. I think we're woefully underinvested on primary care. All right. So thank you all for kind of being here at this point. I encourage all of you to stand up and stretch your arms. We're in the home stretch. Take a deep breath. Believe it or not, we've been through about 90 minutes of material at this point. And my goal is actually to wrap up in the next 15 or 20 minutes to open it up for questions and for us to kind of interact a little bit. Because I will say it's also very hard to talk to a screen for a long period of time. So this kind of gets back to some of the things that we talked about earlier. And I reflected on the importance of the personal statement and kind of our mission statement, if you will. And I also often like to say it's our superhero origin story, right? Like, that's the reason why we got into medicine. And I think what ends up happening a lot, especially when I was a medical student, I thought, okay, if I just show up, the world will change, right? Like, I'll get my MD or my DO, and I'll go out and do good in the world, and then things are going to change. And unfortunately, it's not that simple. We really need to spend more time in that occupy the ground area to change the world. And incidentally, I want to give full credit to Jim Herman. Many of you may know him, who shared this idea at a talk, and I had to borrow and steal it. And I think this gets at I would say the statement that I made earlier, become the physician you wrote about in your personal statement. I think this takes it to the next level. It turns it to 11, if you will. Become the physician leaders our patients and communities need us to be. So as you've seen in this journey into the world of ACEs, there are things that we can do in our office, right? We can connect patients to a therapist. We can treat their substance use disorder. We can treat their diabetes. We can treat their hypertension. We can treat their heart disease. But there are things that are upstream that are not impactable by a prescription. Things like community safety, things like classes for young parents on how to be the best possible adults. I'm sorry, best possible parents they can be. There's conflict resolution. There's creating safe spaces. There's lots of opportunity to impact the world that lives upstream from our patients that can make a difference. And I often think about this one patient that I had early on in my career. I was seeing them at a community health center, much like the ones that I currently work at now. And he had kind of borderline hemoglobin A1C, borderline blood pressure, borderline cholesterol, metabolic syndrome, relatively young, and the typical diet and exercise in the assessment and plan, and metabolic syndrome, diet and exercise. And he straight up said to me, he's like, "Doc, I work 2 jobs, and by the time I get home from work, it's dark, and it's often unsafe. And oh, by the way, have you been to our local market? Uh, there's no fresh produce there. So you're telling me to get fresh food and I can't get it." And so, I think he taught me a really important lesson early in my career that, like, just because I write something in the chart doesn't mean that it's going to happen or that it's even possible for the patient. And so one thing that I encouraged him to do was A, to register to vote, but B, also to get involved with his local community and to write to the city council. And over the years, he was able to create lights in the park, which is kind of cool, and at least made it a little bit safer. I couldn't change the fact that he was working 2 jobs, etc., and it didn't really make as much of an impact on the fresh produce issue. But I think being able to empower the patient ultimately was better than me just writing a prescription and telling him to go away and to come back next time. So I think there's ways for us to be impactful for our patients. Again, it's an infinite asymptote. We're not going to be able to fix everything, but we certainly should be finding that thing that we're passionate about and working on that, and that is how we change the world. So let's talk a little bit about primary care spend. It's true, we're the only specialty in family medicine and other primary care specialties where when you spend more, you actually save more money. That's not true for our proceduralist colleagues, and it's not true for our other specialties. But when we spend $1 in primary care, you get $13 in savings, and that comes from data from the Graham Center. And what's interesting about that is, if you think about it, we're, a lot of people say we're like quarterbacks. I never liked that analogy. I actually think we're like a really good general contractor, right? You got to know how to build the house. You need to know when to call the plumber, when to call the electrician, when to call the carpenter. Because if you had just carpenters or electricians or plumbers, what you'd have is a lot of carpentry, a lot of plumbing, and a lot of electricity, but not a whole house. And so, it's really important to have a good general contractor when it comes to your health. And as I mentioned earlier, only 5 to 8% of total healthcare spending in the US is on primary care. Now, imagine if we were able to impact the ACEs aspect of this and reinvest the savings that we would have from those avoided ER visits or avoided subspecialty visits, avoided prescriptions, and reinvest that into primary care. that would be pretty phenomenal and exciting. Obviously, we're not quite there yet, but there are some states that are looking at this. And when they look at primary care spend, they get embarrassed at how low they're spending. And then they actually create policies to create more investment in primary care. So states like Rhode Island and Oregon have kind of led the way here. And you can see in the data that there is more primary care spending. And part of that is this question about value that I mentioned earlier. Um, Many of you may know this individual as Don Berwick, who's sort of the godfather of the triple aim. And, he's not wrong. And I think, you know, uh, it's very hard to expand the impact of what we do to include all aspects of this, right? Because if you just focused on joy or you just focused on patient experience, you may not be getting quality, right? If you just focus on population health, then you're not necessarily focused on the patient experience. So part of it is this balanced scorecard, let's call it, using the old language from the 90s of how do we maximize each of these, right? And I think it's really important to call this joy part out because honestly, like I get a lot of joy when patients realize that the stress of their life is causing them to have certain symptoms. We do the workup, they feel relieved that nothing's wrong with them, but there are things that we can do to kind of help. And it's all about finding those core memories with our patients that is the reason why we got into medicine to begin with. And maybe along those same lines with core memories, the first time I heard the word joy, I just about threw up in my mouth because I was like, joy. But it really does capture that thing that we do with patients. And it's because we're there for them. It's because we've known them for a long time, that we've got their back, that the care that they receive is excellent. So along those lines, there's some of you may be aware that there's a new ACO endeavor called Primary Care Flex, and for the first time in a national work, there's measuring high value aspects of primary care that are patient centered. So if you'll focus on table 2 here, these are all scored on a Likert scale, and the patient gets to determine what that score is, 5 being excellent, 1 being terrible. And so if tell me if these resonate with you and are a better measure of the quality of care that you provide. My practice makes it easy for me to get care. My practice is able to provide most of my care. In caring for me, my doctor considers all of the factors that affect my health. My practice coordinates the care I get from multiple places, and these are the ones that I love. My doctor or practice knows me as a person. My doctor and I have been through a lot together. My doctor or practice stands up for me. The care that I get takes into account knowledge of my family. The care I get in this practice is informed by knowledge of my community. And then over time, this practice helps me meet my goals. And over time, my practice helps me stay healthy. It's those middle ones that make me super excited because I know that those are things that I do really well with my patients. Not are you dissatisfied with the wait times in your clinic, et cetera, which I think a lot of the other standardized surveys do. So I'm excited. I think there's going to be an opportunity for us to kind of redefine what this means. I think the application is due tomorrow. I know that my organization has submitted an application, and I'm super excited about the opportunity to kind of look at what we do for patients using this new methodology and approach. So last few minutes here, and then I think we'll have about 10 to 15 minutes for questions. As Master Yoda once said, do or do not, there is no try. It's weird. I would say, like, even as a PGY22, I still feel some modicum of hope that things will improve over time. And I think part of that is that we've got some smart people who've advocated for us, who've done the research. And I think, if anything, it gives me a sense of agency to know that we as family physicians have the opportunity to kind of lead the future. And that's in every aspect of healthcare. And so as I do this longer, I realize that I do have some power to impact change. And I'm excited about that opportunity. So, about 20 years ago, we talked a lot about patient-centered medical home. And it was kind of nebulous, right? Like this was what the representation of patient-centered medical home was. Foundation of family medicine. We got quality metrics. We have patient experience. We have information technology that gets kind of embedded in that, and then the way we organize the practice, right? Physicianeering is what I would call that. And then on that is this roof, depending on what part of the country you're from, of great outcomes, right? And I think the idea was great. But it was hard to translate into actual care. And as we've had this advent and this kind of move into value-based care to kind of move us from volume to value, people like Tom Bodenheimer in the Annals of Family Medicine, and oh my God, that was 10 years ago, published papers where he looked at what were the characteristics of practices that were doing this really well, and how do we get there, right? And so you can see here, if you just focused on the bottom four boxes, engaged leadership, data-driven improvement, empanelment, and team-based care, we could solve a lot of problems. And that also requires, as I mentioned earlier, investment into our ability to have someone who can do screening for ACEs, for example. That's part of the infrastructure. That's part of the care team. It can't be on us alone as physicians. We need to have that team that's supporting the work that we're doing, and we need to be the leaders of that team, I would argue. So if you haven't read this article, it's still pertinent today. It was from 10 years ago. I should have included a picture of me and Tom. The dude loves to wear sweater vests. And so I have a classic photo of me and him in sweater vests, but I couldn't find it for the purposes of this slide talk. I'll find it at some point and maybe publish it on social media. And the reason is that we're moving in this direction is that the days of just waiting for patients to show up and taking care of whatever's in front of us are going away, because that's the volume-based world. We've become much more sophisticated, and I would argue where we should be spending a lot of our time as family physicians, specialists, we're family medicine specialists, is in that rising risk and advanced illness cohort that you see at the top of the pyramid. Patients that are at the bottom of that pyramid really could be interfacing with us in ways that are technologically driven or driven by people that maybe have a lower license, or maybe even some unlicensed folks that can kind of help navigate them through some evidence-based things. So I think the future is all about reorganizing the way we think about the way we do primary care. I think technology will play a big role. But all of this is in line with kind of the things that we have been focused on earlier in this talk, which is around ACEs. It's that rising risk population that are going to be very much impacted by ACEs, especially those that have had 4 or more ACEs. And as currently structured, it's just going to be virtually impossible to care for them, on this chassis of 20-minute visits or 15-minute visits. We have to think differently about how to make that happen. And I think there are promising examples of how we can make that happen. And I think certainly in the health center space, we're beginning to have that conversation, because as you're aware, in the health center space, we're beholden to HRSA on volume-based performance, meaning they expect a certain number of visits per year based on the population. And I think there's a HRSA train and there's a CMS train that are kind of hurtling towards each other, and we'll see which one wins out in the end. I think it's going to be CMS, but we'll see how it goes. So in short, I think a lot of what I'm trying to say here with the ACEs piece is that we really should be focused on health in all policies. This was me about, I don't know, 8 years ago in front of the Capitol, I was asked to speak about the Affordable Care Act and the impact it's had on our patients. And a lot of what I talked about was, there's 10% that I can impact in healthcare, but there's so much more that patients bring with them to their visits, and a big piece of that is ACEs. And so hopefully today you've been sort of informed and inspired to think about how to do the screenings, and then to think about how to structure your practices in such a way that you can make an impact for your patients, and to begin to kind of think outside the box on how to connect your patients with some of those community-based services that they may need should you identify 4 or more ACEs. As he who is not related to me once said, a goal is not always meant to be reached. It often serves simply as something to aim at. I'll say, again, as a PGY22, I think there's, and I guess being at the middle point of my career, I think there's so much work to be done to fix the structural problems in the healthcare system. And I continue to believe that primary care and family medicine is the answer to that. And I think a large piece of this is going to be unlocked with our opportunity to kind of identify what's going on with our patients. Imagine if we worked and impacted a whole generation of children and teens right now because we were able to mitigate the impact of ACEs. And based on some of that data that I shared earlier, you look 20 years from now for the patients and kids that we're impacting now, how much more we can do with the healthcare dollar if only we can unlock that, right? And make that something that would be possible. Then I feel like all of us could be the physicians that we wrote about in our personal statements, and we become the physician leaders that our communities need us to be. And none of this happens alone. This happens because we've got community. This past year, I served as a liaison on the Commission for Quality and Practice, and I'll tell you that brain trust of family physician experts from around the country. If only we could lock ourselves in a room and be the architects of the future, we could really make an impact. But the reality is we live in a world where there's perverse interests, there's competing interests, and I think part of it is for us to learn to use our voices. And a lot of that is in advocacy, right? It's advocating for our patients, it's advocating for our neighbors, so that we can provide the best care possible. And with that, I'll thank you all. And I'll stop sharing. Actually, I'll leave this up for just a moment. And then I think we've got exactly 10 minutes left. So I'm happy to take your messages from you. And that's my mobile number. So feel free to write that down. And I will stop sharing and see if anybody has any questions or comments. Stunned silence.
Yeah, I just submitted a reminder in the chat for everyone to claim their CME by completing that form. It's also in the email that I'd sent out earlier today.
Great. And maybe, and feel free to put this in chat if you wish. I'm kind of curious, for those of you that are in the audience, how many of you are currently screening for ACEs, and are you getting paid for it? I'm just kind of curious to know what the landscape is. As I mentioned, here in California, we do get paid for it, but it's only if we're seeing Medi-Cal patients or Medicaid patients. The commercial plans are not paying for it. Okay, sometimes screening, not billing. Yeah. So I think that's an advocacy opportunity, right? To look at that. And I think there's some real data there that, as I presented, that could be of interest to legislators and also health plans. So just something to think about. And I did share the link to the article with Kathy. I hopefully we'll be able to distribute that, but you can also look it up. I think it's open source through Health Affairs. Great. Any other questions? Dr. Hastings, you turned your camera on. Was that with intent to ask a question or more just to say hi? Just to say hi. Okay, excellent. Great. Oh, thank you, Kathy, for sharing the article. Well, I certainly hope that you found this to be informative. Dr. Asaro, I appreciate your feedback. And Kathy, I wanted to thank you personally, for thinking of me and reaching out to me. And I think it was one of the AAFP staff that had reached out based on the history of me working on this through the commission. But I'm super proud of the fact that our specialty is a leader in this area, and we'll continue to push the envelope here and continue to work to make health primary for our patients. So want to thank all of you for your time and your attention this evening, and look forward to continuing to interface with you.
Thank you, Dr. Lee. We appreciate your time this evening.